Thank you all for coming. Are there any students in the audience? Yeah, there are a couple. For those who don't know me, my name is Mike Stillman. I'm one of the Associate Program Directors for the Medicine Residency Program. And some of you know this, some of you don't. I actually have a faculty appointment in two departments here. I have a 70% appointment in internal medicine and a 30% appointment in neurosurgery in the division of PM&R. And what do I do with the 30% of my time over there? I have a little bit of protected time for research, but I do mostly clinical work. I run a couple of clinics a week over at Frazier, and the original intent was just to help take care of the people over there living with spinal cord injury, but the clinic has expanded, and I take care of some other people with chronic disabilities. You see two other names up here. One's Craig Smalley, and he's a master's level engineer. He's not here with us today. He's not sharing the podium, but I just want to tell you all that his fingerprints are really all over this presentation and the work that we're going to present to you today. He's in every way a third and equal member of our research team. And then the other name you see there is Karen Frost-Bertocchi, who's sitting over here, and she is actually going to split the lecture with me. We decided to do a little bit of an unorthodox presentation, do a 50-50 on this. She's a PhD MBA at the School of Engineering, and we've been working very closely together for the last year. And because there are so many residents and students here, I just want to make a comment about mentorship. You all know Dr. Casper really prioritizes mentorship, and that's one of really the selling points of our training program. And I want to tell you that when you're looking for mentors, it's fine to look in your own division or your own department, but something Karen's taught me is that you can look in other schools in the university or even outside of the university. I met Karen very early in my stay here, right after Stevie and I moved here, and she's really in many ways become my most important academic mentor. I didn't have much research background. I'm still kind of green in the research areas, and she's really taught me a lot about methodologies, how to ask the proper question, how to go about gathering data to answer those questions, how to write in a scientific manner. Some of you know that I write a lot, but it's really more narrative style, and you know, scientific writing is an entirely different beast. How to prepare documents for IRB. So I learned a lot from her, and I think that's a lesson for all of us. So Carrie and I met over dinner about a year and a half ago, again, right after we moved here, and we decided that we really had potential overlaps in our professional interests. And Karen does a lot of work looking at accessibility and safety of public transportation systems in Louisville for people who use wheelchairs in the community. And so you could see that there were really potential areas of collaboration. We decided that we wanted to start doing some research together. And this presentation, Stepping Up for Those Who Can't, Accessibility Issues in the Clinic, is really the outcropping of some of the work that we've been doing together. And this is only the second time we've given these grant rounds, and these data haven't been published yet. So, you know, we're essentially trying this out on you and giving you a heads up on the work that we've been doing. And we're really interested in how people with chronic disabilities and people who use wheelchairs in the community utilize and access medical services. And what we thought is that we would start this presentation just going over the research, what the research tells us about healthcare utilization for people with disabilities, and then tell you about some of our own work. And so we started with this literature search, and one thing I think you'll notice as I tell you about some of these articles is that, first of all, the literature in this area is very narrow and not very deep. And so there are a lot of questions that really remain unanswered. And another thing I want you to think about is that disability itself is a very vague term. In federally funded programs, there are 47 different definitions of disability, and they really all, in one way or another, have to do with limitations in function, whether it's in the community or physical limitations. But you can imagine that as they have to do with limitations, they really encompass conditions as dissimilar as knee arthritis and schizophrenia. And so it's very difficult to extrapolate from a greater body of literature on disabilities and make comments about certain subpopulations of folks living with disabilities. And so that's really one of the challenges in this area. But when we started thinking about access to healthcare, we really realized that there were three different facets of it. The first are just subjective reports, and I pulled these four representative articles. These are all pretty well-known articles in the rehab literature. The first one was by Albina Beltman. It came out in 2001. Interestingly, this is a small article, and it's really not in a very well-known journal, but this is a pretty well-quoted piece. She sent out 1,000 surveys to folks living in the Toronto area, either who have been discharged from rehabilitation hospitals recently or who are members of local disability organizations. And she just asked them about access to care. And what she found out is that 18% of them had difficulties obtaining physician services, 8% of them had been specifically denied physician services based on their disability, and about a third of them had reported difficulties using all of the equipment in their family physician's offices. Now, there were methodologic concerns with the study, one of which was that she had a very low response rate. It was about 20%, and so there was a concern that maybe there was some sort of like axe to grind bias, that just people who were really lathered up, who had difficulties with the medical system, were the ones who were motivated to answer the survey. And yet attention must be paid to those numbers, and they'll be mirrored in another study that I'll tell you about. Philo Cole put out a pretty well-recognized study in 2006. This was more of a narrative-based study. He just assembled a group of folks living with disabilities in Northern Virginia, kind of put a microphone on the table and said, tell us about your experiences with healthcare. And he described a high rate of structural, environmental, and process barriers to care. And structural, environmental barriers to care are physical barriers, the narrow hallways, inaccessible restrooms, and the like. They're things that we would ordinarily just think of as barriers. But the process barriers are more subtle but equally powerful. These are attitudinal barriers, so staff who are ill-prepared to take care of folks with disabilities, physicians who don't know enough about their patients' disabilities to provide them the thorough care that they deserve. Morrison put out a study in 2008 that was very similar to that one, but she had two different focus groups. One was a group of people living with disabilities in California, and one was a group of healthcare providers trying to take care of them. And the providers were really of all stripes. She included assistants and nurses and social workers and physicians. And what was interesting about that study is that, as you may expect, the healthcare seekers said that staff weren't really sensitive to their needs, and that the facilities were inaccessible, and that they really didn't have enough time with the docs to get the kind of thorough care that they needed. But the healthcare providers agreed with all those charges. They weren't defensive about them. They said, you're right, we really do have a problem here. So this study was notable for the convergence of opinions between patients and healthcare providers. And then finally, we have a study by Donnelly, came out in 2007. She's a Canadian researcher. She teamed up with folks in the UK and at the Craig Center in Colorado, which is a big rehab hospital. This study specifically looked at how people with spinal cord injuries get their care. And it's a pretty broad range study. It asks about what types of physicians they use, which physicians they would approach with different problems and such. So there are a lot of questions in there. But for our purposes right now, 27% of the U.S. Respondents, again out of Colorado with spinal cord injuries, said that they couldn't use all of the equipment in their primary care offices. So much like the development study from 2001. Another facet of access to care we can look at is physical accessibility. Interestingly, the ADA came out, the Americans with Disabilities Act came out in the early 1990s, so it's been on the books for almost 25 years, but these are the only two studies we could find looking at how medical facilities comply with ADA regulations, which are pretty reasonable and very specific. The first one was put out by Grayboy, and she surveyed all of the primary care practices in a single Texas county. So by primary care, she included OB-GYN and family medicine and general internal medicine. And this survey that she sent out was also pretty broad and far-reaching. She asked about physicians' attitudes and practice patterns. She asked them, how they care for people living with disabilities, if they had ever had to refer disabled folks out to other practices because they couldn't handle them themselves. She asked them about whether or not they examine people who come in wheelchairs while they're still in their wheelchairs. But she also asked them about compliance with the ADA. And the way she did it is for each practice, she set up a fraction, if you will, and the denominator was the number 17. She just picked 17 core requirements of the ADA governing public spaces and hence medical offices. And then the numerator for each practice was a combination of those 17 requirements which had either never been problematic or which had been problematic before the ADA was enacted and then they had actively addressed. So you can see that each fraction for each practice represented essentially compliance with the ADA. And the average responding practice said that it was about 75% compliance, so maybe not as good as we'd like to see, but not as bad as we would have feared. What was interesting, though, is that when she asked specifics about office accessibility, she found that virtually none of these practices had platform scales, right? So people coming in wheelchairs couldn't get weighed, and you all know from AIM that's a really essential part of primary care. And under 40% of them had adjustable examination tables. Now, the ADA says that every medical office has to have at least one adjustable examination table that we can drop to between 17 and 19 inches of the floor to allow for safe and easy transfer of folks with disabilities. So the vast majority of these practices didn't have those tables. Also notable were the physician responses. The one that really struck me is that 20% of them said that they routinely examine wheelchair users while they were still sitting in their wheelchairs, and another 35% of them said they did it part of the time. So this is not what any of us would expect of ourselves in AIM, and maybe that's not surprising, but it really it's a worrisome comment on how we're treating people with disabilities. Jill Sanchez put out a study a year later in 2000, and it was like grade boy +1. So she sent out a survey to 40 outpatient practices in Illinois, and she asked them about accessibility of their physical space. But then she followed up that survey with on-site inspections, and what she found was really this kind of reporting gap on accessibility, right? So she sent out the survey, and they almost all said, yes, we're fully accessible, we can handle folks in wheelchairs, not a problem. 40% of them said that they had ADA compliant adjustable examination tables, but when she actually went on site, she found that there were significant concerns with accessibility. Virtually none of them had ADA compliant restrooms, and only 17% of them had adjustable height examination tables. So again, there was a gap between these offices, kind of self-perceptions of accessibility and actual accessibility during site inspection. And then the last facet of access to care we could look at are receipt of expected services. That are, do disabled folks get the same kind of routine and preventative care that we would all hope and expect to get? Leighton Chan put out this study in 1999, and this is actually a very robust study. He had access to records of over 15,000 Medicare recipients, and he also had information about their ADL limitations and how many ADLs were they limited. And what he found is that people who were really profoundly physically limited, who needed help in 5 ADLs, let's say, received fewer flu shots and fewer mammograms and pap smears than people who had barely any limitations in ADLs. Sherry Lavella is a researcher in the VA hospital. She put out a lot of studies. This one is really probably the best known one from 2006. She had 2 subject groups that she was looking at. One was a group of women in the VA system with spinal cord injury, and the other was a group of women in the VA system who was not injured. And she looked at receipt of preventative services, and you can see that there were significant differences between the 2 groups of subjects in receipt of colorectal cancer screening, routine dental care, mammography, and pap smear. And when this study came out, a lot of people were very concerned about it because they said, you all know this. They said, my God, the VA is so uniquely capable of taking care of people with disabilities and frail and elderly people. So if this gap exists in the VA system, it must be that much worse in the community. And in fact, that question is still very controversial. We haven't had a definitive answer about that. About the same time, Mark Johnson, who was a trainee at UMDNJ, who's the Kessler Institute in New Jersey, put out a study looking at that. He had 199 spinal cord injury subjects in New Jersey. He asked them a great number of questions about their health care, but particularly about receipt of preventive services. And he was able to compare their answers to a national database that's called the Behavioral Risk Factor Surveillance Study. It's put out by the CDC every year. And the CDC just basically cold calls people across the country and asks them about various aspects of their health care. So you can see that's a very robust data bank. And you can see that there really were no differences in receipt of colorectal cancer screening, routine dental care, and prostate cancer screening. Remember, this was in 2005 between the folks living with spinal cord injury in New Jersey and the national sample of non-injured folks. So, I just wanted to spend some time going over that literature with you, and I hope you'll appreciate that there are really a lot of questions we could still legitimately ask about how people with disabilities get their health care and what kind of care they're getting. And this was really the impetus for our work. So we put together our first collaborative study called Utilization and Access to Health Care by Individuals with Mobility Disabilities. And you can see we were lucky to get some internal university funding. And we had 2 main objectives. The first was to characterize patient usage and barriers to usage of primary and specialty care providers. So we're really looking at physician utilization. And the second was to assess healthcare provider awareness and compliance with ADA regulations. And this was a more local study, and we'll tell you about that. And we had 2 tasks mirroring those 2 objectives. The first was to develop a healthcare access and utilization survey of wheelchair users. And the second was to do an ADA-based assessment of physician offices and an accompanying clinic manager survey about knowledge of ADA regulations. The study design was cross-sectional and observational. We got IRB approval through the University of Louisville, and some of you may know that's really a bear. We felt very particularly proud of that. It's a terrible process. And we used an internet-based survey through SurveyMonkey. We employed a nationwide recruitment strategy. Karen called the ADA coordinators in all of the 50 states. We had significant support from the Reed Foundation, from Easter Seals Project, from Centers for Independent Living, and from the Arthritis Foundation. They didn't give us any money. They were very generous in advertising the URL site where people could get online and take our survey, and we're really grateful to them for that. And we had pretty bare inclusion criteria because we really wanted robust participation in the survey. So people had to be 18 years or older who participated. It had to be either 1 year or more out of a spinal cord injury or development of whatever medical condition led to their wheelchair use. They needed to use the wheelchair as a primary means of mobility in the community, meaning more than 50% of the time. And they had to have access to internet. Now, what's really interesting about this one, and Karen will tell you a little bit more about that, is that we thought that this was going to be a very inclusive strategy. We thought most people have internet access, and this will allow people with, let's say, severe physical limitations to take the survey. And this criteria probably introduced bias to our study that we'll tell you about. It definitely wound up, set us up with a skewed patient population or subject population. Survey questions, we asked a great number of them. We asked demographic and socioeconomic factors, really with an eye towards seeing which factors predicted utilization of healthcare, access to healthcare, and the quality of healthcare received. So we asked people how old they were. We asked them the size of the town they live in. We asked them if they were married or single and if they lived with anybody. We asked them about what kind of education they had, what their average family income was. We asked them how they get to their healthcare providers and what type of wheelchair they use. We asked them all these questions. We asked them the number of primary specialty and emergency care visits they had had during the past year, so again, getting the physician utilization. We asked them about barriers encountered at their primary and specialty care clinics. And we split it up into 3 different groups. There were facility barriers. So if you all are going to the AIM clinic as patients, the facility would be ambulatory care building. And then we asked about clinic-based barriers, so that would be AIM clinic itself. And then we asked about barriers they encountered in the examination room itself. And these questions were purely subjective. So for instance, when we asked them about accessible parking at the facility, we didn't say the ADA requires that every facility have so many parking spaces available to folks living with handicaps. Did you find that to be the case? We just said, have you had any problems with parking? Have you had any problems with inaccessible hallways or restrooms? And then we also had routine and preventive care screening questions. So there were age-specific questions. We asked about screening colonoscopy. We just asked for participants over 50 if they had had a colonoscopy within the past 10 years. We didn't ask about flexible sigmoidoscopy or stool cards for a couple of reasons. First of all, those really aren't a sensitive screening test, so I didn't really care about those. And the other thing is that we thought it would get tricky to ask people about all these testing modalities. So we didn't want to say if you had a colonoscopy within 10 years or a sigmoidoscopy in 5 years or stool cards annually. We just thought that would get tricky. We asked about pelvic exams and pap smears within the past 3 years, so that's in line with all national recommendations. Mammography was difficult because you all know there are such disparate recommendations nationally. So ACOG recommends annual screening after the age of 40. USPSTF recommends biannual screening after the age of 50. This is on me. I didn't really know what to do with that. I kind of split the difference. So we asked if women had been screened annually with mammograms over the age of 50. Most of the national surveys on receipt of preventive care ask the USPSTF question. They say, if you're over 50, have you had a mammogram in the past 2 years? So the fact that we asked a different question makes it a little bit difficult in cases for us to compare our answers to national surveys. We also asked about preventative care, pneumococcal vaccination, bone density testing, flu shots, and dental care. And these are the beginnings of the results. So these are the demographics. We had 470 people participate via internet with our survey. You can see that there was a preponderance of female participants. This is not unusual for national studies looking at folks with disabilities. You can see that the plurality of participants were in the 50 to 64 age range, but that there was a good distribution of age ranges represented. You can see there was that 50-50 split between people who were married or widowed or single, and you can see that by far the majority lived with a spouse or family member rather than alone. Interestingly, on the education, look at this. Nearly 60% of our participants had a college degree or postgraduate degree. That is a very skewed population, both nationally and for studies looking at people with disabilities. And I think this is probably the outcome of this being an internet-based survey. Again, we were trying to be inclusive, and we wound up with this. And I think this has certain implications for our data and for our outcomes, which I think we're all still grappling with. You can see about 46% of people use public insurance, Medicare, Medicaid, or the VA. Some use private, and then the others had a combination of the 2 types of insurance. More people use manual wheelchairs than power wheelchairs. And you can see that the plurality of people hadn't been using a wheelchair for very long, but that there was a good distribution again, and nearly a third of people had been using a chair for over 20 years. And we asked about medical conditions leading to wheelchair use, and you could see over a third of the participants were spinal cord injured. And in fact, we did a subset analysis of the data gathered from that particular group, and we just found out that was accepted for publication. We just found out this morning, which is exciting for us. But look at number 2, rheumatologic diseases, rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. Almost 22% of the wheelchair users had one of those conditions. Now, I didn't know this, but I don't know if any of you know this. Arthritis is the second leading cause of wheelchair use in this country. Did anybody know that? I didn't know it either. So stroke is number 1, arthritis is number 2. I think it's because in England, we don't see a lot of folks with such severe arthritis that they come in wheelchairs. We see people with bad back arthritis or knee weight, but most of them are using walkers or canes, or they're just coming in under their own power. So that was very surprising to me. And then you can see there was a good distribution of other diagnoses: stroke, spina bifida, CP, multiple sclerosis. And this is a slide about physician utilization, and I want to try to ground this for you. And again, this question hasn't specifically been asked of wheelchair users. That is, what types of physicians do you see and how many physician visits a year do you make? So it's hard for us to compare these data to similar data, but I can tell you what we know. The Mark Johnston study, that's the guy who had the 199 spinal cord injured participants in New Jersey, and he compared their answers to the national survey from the CDC. He asked those folks who their main doctor type was, and 40% of them said an internist or a primary care doc, and 60% of them said a spinal cord injury specialist. So in that study in 2005, there was not robust utilization of primary care services. The Donnelly study, she's that Canadian woman who collaborated with folks in the UK and at the Craig Center in Colorado, and also did a spinal cord injury specific study. She asked people about which types of doctors they employ. 75% of them said they had a primary care doc only, and 40% of them said they had a combination of a primary care doc and a spinal cord injury specialist. So again, not all of them were seeing primary care docs. And then we know from the U.S. Census Bureau that the average American makes just under 4 physician visits a year, 3.9 visits a year. So in this cohort, these 470 wheelchair users who responded to our survey, you can see that the plurality made between 3 and 5 visits to both a primary care doctor and a subspecialist every year. So really robust utilization of physician services, and virtually none of them did not see a primary care doctor. That was an interesting finding, and that was unexpected. And I think, at least for the first half of the presentation, this is the money slide. I told you that we asked them about barriers they encounter when they go for primary care or specialty care. And again, these were subjective questions, and you can see we split them up into facility-based, clinic-based, and exam room barriers. And this is really an indictment of our healthcare system. Over 20% of respondents said that there was no accessible parking in their primary care facility. Over 30% of people said that the exterior door to their facility, again, like the ambulatory care building, was inaccessible to them. The clinic barriers are present, but in not such high numbers. Between 10 and 20% of people said that the restrooms, the hallways, and the clinic doorways were inaccessible to them. And look at these examination room barriers. Over 20% of respondents said that the exam rooms themselves were inaccessible to them. They couldn't accommodate their wheelchairs. Over 50% of people said that the examination tables in their primary care offices were inaccessible to them. Over 40% said that there were no transfer aids available, and nearly 30% said there was no assistance for transfers available. Now, this is very interesting. The ADA does not specify what type of transfer aid you need to have in a medical office. You could have a Hoyer lift, you could have a slide board, whatever. But what you can't do is grab somebody under her armpits and under her knees and lift her up on the table. That is not good. And you can't just stick a sheet under her and lift her up on the table. We actually called the ADA hotline and asked them that, and they said no. The other thing is, you cannot tell a patient with a disability that he or she needs to bring his or her own transfer assistant. So you can't say bring a brother or bring your spouse or whatever and have them help you get up to the table. You have to be able to provide that yourself. And it looks like we're not really doing that for people. We asked them about quality of care. We asked 3 different questions. We asked if they had been weighed during a typical primary care visit. We asked them if they were asked to get into a gown or undress from their street clothes. And we asked them if they had been examined in their wheelchairs. And you can see that just over 40% of them had been weighed. And again, this is routine care and AIM. This is very important to us. We're fighting an obesity epidemic. Virtually none of them really were asked to get into a gown or to undress from their street clothes. So these folks are getting examined fully clothed. And by far the majority of them have been examined in their wheelchairs. Now, I told you that we had done a subset analysis of subjects with spinal cord injury, and these numbers were much uglier for the SCI participants. But basically, none of them ever get weighed, because nobody ever has platform scales available. About 90% of them get examined in their street clothes, and about 90% of them get examined while they're still sitting in a wheelchair, which is pretty unacceptable. And then we asked about age-specific screenings. I told you we asked about colonoscopy over the age of 50. This number was up near 70%. Nationally, if you ask people if they've been screened for colorectal cancer, if you ask them if they've had a colonoscopy, stool cards, or a flexible sigmoidoscopy, about 80% of them said yes. So this number is actually pretty good. Mammography, I told you we asked a little bit of a different question. We asked about an annual screening over the age of 50. Nationally, if you ask women over 50 if they've had a mammogram within the past 2 years, that number is up near 80%. Ours was just under 70, so again, probably not that bad. Pap smears are problematic. So we asked a question based on all national recommendations. If you had a pap smear and a pelvic exam in the past 3 years, nationally that number again is up near 80%. Ours was 60%. And then dental care, almost 70% of our respondents have had routine dental care in the past year. Answers to that nationally are, as you can imagine, very state-specific, but in Kentucky, actually, almost 70% of people get annual dental care. So that number wasn't that bad either. Maybe these surprised us. Maybe we were expecting these to look worse than they did. So with that, I'm going to turn the presentation over to Karen.
Thanks. Hi, I'm Karen, as Mike mentioned. And I just want to add something before I get into this, that one thing Mike failed to say when he was talking about mentors and looking outside of your own specialty practice or group, that it also works for those of us who are on the other side of the coin. I've never been so motivated by someone to work with them and do research. And even though there's been some training, I've learned just as much from Mike as we've gone through this process. And he has basically put the dynamite where it needed to be put to keep things going. And if it weren't for him, we would not have had he would not have had his first author paper being published in archives soon. So it goes both ways, and it's just great always to work with someone who's very passionate about what they're doing and has a lot of energy. So I'm going to take this time now to talk about the second half of the study. And this, as Mike said, was a more local cohort. So what we did here is we wanted to look at kind of take some of those national studies that we had seen where they had looked at like gaps between what the practices said they were compliant in terms of ADA and whether or not they really were if you did an on-site assessment. So that's what we did here. We did on-site assessments throughout a convenient sample of Kentucky One practices. All the clinics that we selected were located in Kentucky One-owned facilities. And concurrently, we surveyed the clinic managers on a series of questions to gauge their awareness of their responsibilities for equivalent care for people with disabilities. We pulled four. On this didn't go. Sorry, didn't have the clicker. So we used two sources to go through to set up our assessments and our surveys. The first primary source that we used for the site assessments was this great brochure. It's no more than 20 pages. It's put out by the U.S. Department of Health and Human Services. It's available online. You can download it. It's got lots of pictures, bullet points, extremely easy to use. And this basically tells you the bare minimum of what you're required to provide in terms of accessibility for individuals with mobility disabilities. And again, we limited our study to mobility disabilities. We also relied in part on the ADA accessibility guidelines for buildings and facilities. So this is put out by the U.S. Access Board, and what this document gave us was a little more information about doorway widths, measurements, and architectural specifics that we needed to know. For our assessments, we basically took the approach of a typical patient going to the clinician, going to the healthcare office, and what their pathway would be getting through the clinic. So we started with the building entryway, moved into the clinic doorways, did measurements, the sign-in area, the reception counter heights. We looked at the hallway widths on the pathway to the exam room. Were the turning areas to go from one hallway to the next, were they able to be navigated by a wheelchair? And there on the lower left, you can see we also use the ADA definition of a common wheelchair. And that is the benchmark for making sure you have accessible facilities or an accessible space. A common wheelchair is defined as a mobility device that is 30 inches in width by 48 inches in length. From the hallways, we moved on to the restrooms, needed to see could patients get into the restroom. Did the doors open in a swing, a doorway swing, so that they could navigate around the door into the restroom? Was there sufficient clear floor space in front of the toilet to navigate and maneuver into position? Were grab bars appropriately located and present so that an individual could transfer? Because there's no reason going into the toilet facility if you can't access the toilet. We also looked at the turning area in the restroom or the stall to make sure that they could also navigate back out, so they could enter the restroom forward facing and also leave the restroom forward facing. And finally, we looked at sink heights and clearances to make sure that they could wash their hands after using the facilities. We moved on to the exam room. And in the exam room, we similarly looked at the accessible route. So was an individual able to enter into the exam room, navigate with the size of their wheelchair? Was there sufficient clear floor space adjacent to the exam table so that they could get to the exam table and able to position their wheelchair and themselves so that they could do a transfer? Again, turning space came into play there. The exam tables, by the ADA definition, they need to be able to be lowered between 17 to 19 inches above the floor height to assist for transfers. And for a lot of wheelchair users, we need to keep in mind that we looked at rails or armrests, the provision of them. Were they available? Either if it was something that could be available elsewhere in the clinic and could be brought into the room, or were there any arm rails on the exam table itself? A lot of people cannot maintain a position, either supine, prone, sideline, without having some type of positional support. So this is the convenient sample of clinics that we use to do our site assessments and to do our clinic manager surveys. And we contacted Charles Workman, who at the time was the Executive Director of Facilities at Kentucky One Health. He got in touch with the various people so that we could contact them and get their approval to come and visit their facilities and go in and do measurements. You can see we got a decent sampling of 4 different locations at U of L. So on the far left side, you see that's the actual site or campus site. At U of L, we looked at the healthcare outpatient center. We had 5 clinics that we visited within that building. We went to the ambulatory care building, visited 1 clinic. Guess you could guess whose clinic that might be. Jewish Hospital, the same thing. So we visited 4 different buildings, the various numbers of clinics within, and we also did two minor road trips to Jewish Hospital Medical Center South and down to St. Mary's and Elizabeth's. And here you can see the percent of clinics that met the ADA requirements based on the barrier categories. And I want to apologize, before you were looking at the slides, I changed the color scheme on my half of the slides. I apologize, I shouldn't have done that. But red here now means non-compliant. So when you look at the same breakdown that Mike provided, you have the facility barriers, clinic barriers, and exam barriers. You can see where the non-compliance was. Very few clinic barriers in terms of the clinic door, so leading into the clinic space. However, a lot of restrooms within the clinic space came up as non-compliant. And within the exam room, a lot of exam barriers, more than 90% had ADA non-compliance. And we're going to go through those in a little more detail. So first, with the restrooms, the primary problems with accessing the restrooms were insufficient space to maneuver through the door or within the restroom. So that was the primary issue with patients trying to access the restroom within the clinical space. The second one, which maybe many of us would consider more of a minor detail, and it could always be added to very easily by installing additional grab bars, but in many cases we found that grab bars were either not present, or if they were, they weren't positioned in a way that a wheelchair user could use them effectively to transfer onto the toilet facilities. Here you can see this is the exam room space, and this is the percent of the exam rooms that met the ADA exam room requirements. On the left side, you can see there's the percentages for compliance, and on the bottom, these are 3 of the specific areas that we looked at. And the first one was the wheelchair maneuvering space. So roughly, 90% were compliant, and about 10% didn't have of the facilities that we measured, and there were 32 in total. So about 10% did not have sufficient maneuvering space for the wheelchair user to get in or maneuver and navigate within the exam room. More importantly, the exam tables themselves. As you can see, just like Mike said in the national data or in our survey data, we had roughly 50% of our national survey said that they were not able to access or use an exam table because it wasn't height adjustable. We found the same thing with our very small local study looking at height adjustable exam tables. So over 50% of the time, the physicians couldn't get their patient onto the exam table. In more of the buildings and the exam rooms, we had the absence of movable rails or armrests. Again, these are issues that could easily be added to, or also you can help with positioning supports even with rolling tiles. But it's something that people need to be aware of, is positioning the patient, making sure that they're able to stay in that position. Because the maneuverings, let me just go on to the next one. Actually, I'll get to the clinic manager study and add to. So while we were doing the measurements of the clinical spaces, we concurrently provided the clinic managers with either a hard copy of a survey, or we provided them with a URL to go on SurveyMonkey and take a survey, asking them questions about awareness of ADA. We again went back to the same brochure document, gave us a good overview of what clinics need to be aware of and what provisions they need to make for accessibility and equal care. As I said, internet-based survey primarily, but we did do some hard copies. We did telephone follow-up calls to make sure that we got adequate response from the clinical managers. And again, this was a convenient sample of those managers from the clinics that we did our site assessments. So here are some of the questions that we asked them. First, we wanted to know, based on the clinic manager's estimate of their patient population, what was the percentage of individuals who come to that clinic who use a wheelchair? Then we asked them whether or not staff had received ADA training related to patient care. What was the availability of accessible equipment, namely, did they have an accessible weight scale, a height adjustable exam table, and were there transfer aids or staff assistance for transfer? And as Mike said earlier, the ADA doesn't require that you have transfer aids if you have staff assistance, but that staff assistance has to be trained and willing and able to provide transfer assistance to the individual, and that's very important in what we found later. We asked them what their standard protocol was for conducting routine exams and minor procedures, namely, did they have patients change their clothing, or did they do the procedures while they were seated in the wheelchair, or did they transfer the individuals to an exam table? And we came up with a bit of a post-test, so we asked them afterwards, after they'd gone through all these questions. Now, having gone through those questions, did they feel that there was a need for staff training regarding the ADA for their patient population? So based on the different campuses and the different buildings, this is the average percent of patients that the clinic managers reported were wheelchair users that visited their clinics. And as you can see, the Rudhart-Lund building came in with roughly a little over 25%, I think, of the patients going into those clinics in that building were wheelchair users, followed by down at Plaza One at St. Mary's and Elizabeth. The rest of the clinics that we queried had under 10% of their patient population that they estimated were wheelchair users. And here you can see the response from the clinic managers when we asked them what type of accessible equipment they had available. So the first one for accessible weight scale, roughly 70% of the clinic managers stated they did not have an accessible weight scale. And the accessible weight scale can be available in the clinic, or it can be also located nearby. So if it's not in your clinic, but it's in the clinic down the hall, or it's in a common space between clinics that's able to be used, that's acceptable. But in this case, there was neither an accessible scale in the clinic or in a nearby area that was available for their use. For the examination tables, we had slightly fewer said that they did not have an accessible or a height adjustable exam table that went down to the 17 to 19 inch. Here, though, we had a fair amount, which was surprising. Over 20% of clinic managers said they were unsure or they skipped that response. So I personally take that as a no. I have a hard time thinking that a clinic manager wouldn't know whether or not they had a height adjustable exam table. And finally, we asked them about transfer aids or transfer assistance. And here you can see very few said that they did not have either aids or transfer assistance. So with the ADA exam table, that was something that we were visually able to see when we did our site assessments. But in terms of a weight scale or transfer aids, those are items that we may not have been able to see when we visited and did our measurements within the clinic. They could have been located down the hall. Transfer aids could have been stored in the closet. So for those two items, we asked some follow-up questions. We asked them the reason that an accessible weight scale wasn't available. And here you can see, for those who said there wasn't, 52% of the clinic managers said, well, they just hadn't ever even considered that they needed it, or they didn't think it was needed because they don't have very many wheelchair patients. Almost a third stated that they just simply asked their patients that what their weight was. We had two clinic managers who said that they don't weight any patients, and one of them was in a psychiatry practice, and the other was a urology practice. Another almost 20% didn't comment on why they didn't have an accessible weight scale. And here you can see when we queried them further on the transfer aid, it turned out that in all cases, the clinic managers were relying on their staff to provide transfer assistance. And they indicated that their staff were trained and willing to assist with transfers. However, when I needed to go back and do some follow-ups with the clinic managers to make sure they were completing the surveys, I talked to a handful of the clinic managers, and I took that opportunity to ask them what they did in terms of their patients who are wheelchair users. You know, how would you transfer that patient? And 3 of the 5 handful that I talked to said, well, we typically ask them if they need to get out of their wheelchair and they can't do it by themselves, that can they bring somebody, can they bring a family member, or they can bring an assistant who can help them. That's in violation of the ADA, but it wasn't, at the end of this study, it wasn't completely surprised to me that these clinic managers were not aware of it. But that's something that we all need to be aware of, because that is a violation, and it's also not providing treatment or care in a dignified or safe manner. It also, I want to point out, is it's not just something that's a challenge then for the clinicians, it's also a challenge for the clinical staff. It can increase, doing patient transfers and not knowing how to properly do them can increase worker compensation claims, adds more time to the clinic. So there are a myriad of reasons why you'd want to properly train people to do this, or you would want to provide an accessible exam table so that maybe you don't have to rely on transfer assistance so much. Here's the responses that we got when we asked them how they performed a minor exam or procedure, or their exam for patients who were using wheelchairs. And here you can see that almost 70% of the time the clinic manager said yes, they did examine the patient while they remained seated in the wheelchair. And when it came to performing procedures, a fair amount did not perform procedures within their clinics, but of those who did perform procedures within their clinics, almost a little over 20% stated that they did perform those procedures while the individual was seated in the wheelchair. This included catheterizing individuals as well. So then here's our pre-test, post-test questions that we came up with. At the beginning, we asked, okay, has the clinic provided ADA training? Here you can see that the majority weren't sure. The clinic managers were not sure whether training or not had ever been provided, but roughly about 30% knew that it had not been provided. Then we walked them through all these questions and asked them at the end, well, now do you think there's a need for ADA training for your clinical staff? And surprisingly, we got more affirmative responses in terms of not needing ADA training. This was rather surprising and a little dismaying, truly. So let me get to some of the highlights between the parts that Mike talked about and myself. Some of the things that are the take-home messages of what we found were the receipt of preventative health screenings for our national survey, nationally recruited survey population were similar to the national averages that we saw for colonoscopy and dental care. The patients who responded to our survey received fewer pap smears than what we saw in the national averages. We recognize that our findings are likely skewed based on the high socioeconomic status of our sample population. And truly, in the future, we would probably add an arm where we would allow for a paper-based survey. We also could have improved that by, say, going after a specific group of veterans through a VA hospital system. We might have gotten a more balanced survey. However, we do want to mention that, although our findings might be skewed, the need for accessible equipment to provide OB-GYN services is an important factor that influences the receipt of the care. So, you have to have the accessible equipment in order to provide the care. So if the equipment isn't there, then the patients aren't going to go and get that service. And I will tell you, wheelchair users call ahead and ask about accessible equipment before they head out on what can often be a very long trip to and from the physician's office. So with our patient survey data, again, we found that despite the high healthcare utilization rates that we saw with the wheelchair users, it still seemed that they were being offered less than thorough medical care. The majority were not weighed during their visits. They were often examined fully clothed while seated in their wheelchairs. And the staff knowledge and assistance regarding mobility disabilities was less than adequate based on their perceptions and what they had experienced. So more locally, how did we fare when we took our show on the road and looked around the Louisville practice areas? We found that within the Louisville cohort that we examined, that the exam rooms are where the barriers to health care primarily exist, to a lesser extent the restrooms. In the exam room, there's an adequate space for the wheelchair user to maneuver or to enter into the exam room. An obvious lack of proper ADA compliant height adjustable exam tables, lack of transfer aids or support rails for positioning, restrooms, inability for the wheelchair user to get in and maneuver to use the facility. And here, so we started looking at the next slide, shows you in terms of exam room equipment. If a clinic were going to either replace their equipment or just go out and fully purchase new equipment to become compliant, what would it take? So you can see in the box, we've got the exam table investment for ADA compliance. Here's 4 examples from 4 different manufacturers. The price difference between the non-adjustable and the adjustable exam table. So if a clinic is just in the process of doing normal replacement, for an additional investment of $1,500 to $6,500, you could have an ADA compliant height adjustable exam table that would probably save your staff a lot of backache and trouble, and would make not only your wheelchair users but a lot of your clients safer and probably happier when they went for their exam. If you were buying it straight out, your investment's between $2,000 and $8,400. That's not a lot of money. And you can also get federal tax credits and deductions that are available for making accessibility improvements. We also looked at the other major equipment issue that needs to be addressed, and that's the accessible weight scale. Again, you can see, non-accessible weight scales not too costly. Definitely between $1,600 and $3,300 if you want to get a good platform scale. Again, though, if you're in the process of upgrading your equipment or replacing it outright, your investment ranges anywhere from $1,500 to $3,300. So again, these aren't expensive investments, and I think they can aid a lot of individuals, not just your wheelchair population. So obvious limitations from our study Our patient survey, our sample was skewed by socioeconomic status. Again, we try to address that through adding a non-internet based arm of the study, trying to do some recruitment with the VA, which would bring us a different socioeconomic flavor to the responses. With ADA site assessments, all of the clinics that we surveyed leased spaces in Kentucky One Health facilities, which means Kentucky One Health is responsible for the parking for the outer facility barriers, but the clinics themselves are responsible for everything within the clinic wall, so they do their own custom build-outs in their interior spaces. And again, we had a convenient sample of clinics and clinic managers for the second half. So what are the conclusions that we can bring from this presentation today? Individuals with mobility disabilities seem to receive less than thorough care than their non-disabled counterparts, and this is something that we need to address. Accessibility barriers that we saw are remediable and not very costly. Accessible equipment benefits not only the patients, but can benefit the staff, and it also can reduce the efficiency, or not reduce the efficiency, increase efficiency by reducing time. And we also need to keep in mind that all of these requirements are the law. The ADA has been the law for over 20 years, and I think as we see more people coming into the healthcare system through Obamacare, the Office of Civil Rights, which under the Department of Justice, they have been seeing in the past 5 years, they've been trending upwards in terms of getting complaints from individuals in terms of accessible health care. So I think the landscape's going to change. We're going to hear more complaints, and hopefully this information can help inform everybody in ways that we can address these. I do want to acknowledge, again, we got some intramural funding, which was very helpful. Kentucky One Health Facilities Executive Director was very helpful to us. And our co-collaborators who aren't here today, Dr. Bertacci and Dr. Williams, provided us with a lot of support with the study design and the concept. Mike would like to answer any questions you have.